I do hope that we are going to proceed in the incoming years even better with all of you together in a common spirit of BANTAO. Thank you. For today's lectures, I need to talk something about the CKD progression and what is the current state of the art. But first, about the presentation outline, I'm going to talk about the definitions, detections, diagnosis, rationale for screening, risk of progression, what it means to have early detection, and what are, in the end, interventions for delaying the progression. Then the standard of care, adjuvant therapies, SGLT2, and non-steroidal corticosteroid receptor antagonist. We all know that we need to manage distinction between early CKD and normal age-related decline, which is 1 to 2 milliliters per minute of GFR per year. And we also know that many of these patients from 1 to 3 CKD stage were not going to come to need for dialysis treatment. Many of them will rather die because of the cardiovascular disease, since this CKD, our CKD, is well associated with cardiovascular risk. And then the high-risk group to be screened are surely diabetic patients, hypertension patients, patients with proteinuria, obesity, etc. But for those who are asymptomatic and with the insidious onset of CKD, of course, that we need some new markers and prognostic techniques who are required in order to have them detected early as possible. You all know about this classification from KDIGO based on the eGFR and albuminuria. So these are two factors at risk we are always evaluating. And usually we do have patients here when there are minor structural changes when we are detecting with biopsies of the kidney. But in fact, that is something which is irreversible in the majority of cases, and we need to have patients detected here with the molecular alteration, we can have detection and then better treatment. And it's true that over the years there are many of these markers, whether it comes from the tubules, from the glomerulus, from marker of oxidative stress, etc., etc. But up to now, we quite agree, I hope, that we have not done a single marker who can be a respectful one and will tell us a lot. Maybe because there is diversity of our nephronal units, because there are many different parts. But still I think that we need other markers. And in that regard, I present this marker, DKK3. Professor Flieser is in favor of this marker. You see the difference, median of 33 in the general population compared to CKD 431, which is increased and is giving a risk of fast progression in the next 12 months. This is very new marker, and the paper is in press from our friend Philip Carla from Manchester. And they are saying that urinary liver fatty acid binding protein is a marker which, in the absence of significant proteinuria, can have a good discrimination value, either when combined with urinary protein creatinine ratio or alone. And what is even more important, that there is cutoff point of 8. And here you see that those who are having above 8, they will progress to the need of renal replacement therapy or eventually to death, compared to those who are having much lower urinary liver fatty acid binding protein. But can we rely on this proteomics? Although we all know that it is a comprehensive technique, which is quantitative description of protein expression, but it's expressing perturbation in the disease. We can easily have a follow-up, but whether we can use it and implement in the regular clinical practice, it's still under question mark. And there are many studies up to now, but all of these studies are for study reasons itself. In this study, 522 patients were followed, and indeed, in those who were found with CKD273 classifier increased, there were rather reduced after 2 years or after 3 years of follow-up, reduced eGFR from 72 to 52 compared to slow progressor who has even improved the eGFR. And you see the relationship, the correlation between the urinary albumin and eGFR, as well as eGFR and CKD273 with a cutoff point of 0.33. Compare with the combination of baseline eGFR and albuminuria with CKD273 and eGFR, we see that the area under curve for the CKD273 is much higher, which is having, in fact, better discrimination ability. But also, proteomics could give us an information about improvement of the patients, which is not standard way of looking at the things. We have performed with this classifier 141 and show that with this classifier we have the best area under curve covered, which means the discrimination and to detect those who are going to improve the kidney function with this in a cohort of 59 validation set of 59 patients. We have done it, and it showed it is much better. What is in fact significant progression? From 8 to 12% of any country population who are with any stage of CKD, the start of dialysis is 0.1 to 0.2. So where is the rationale to detect or to diagnose a lot? In fact, majority of them are not going to be in a need for dialysis. So eGFR decline above 5 milliliters per year or 10 milliliters in 5 years is significant progression. To slow, of course, we need to treat the primary kidney disease, to have strict control of blood glucose level. These are general instructions. Protein restriction in diet, of course, smoking cessation, reducing the weight, treatment of hyperlipidemia and metabolic acidosis, and other CKD complications like anemia, bone disease, etc. Then, of course, strict control of blood pressure with blockade of renin-angiotensin system and reduced proteinuria. Finally, we have nowadays new management strategies. But let's go one by another about this. Have you known that proton pump inhibitors, when you use for long term, they may influence your kidney function? In this cohort of 144 patients with any type of acid suppression, 120 on PPIs and 18 on regular H2 blockers, they were followed for 5 years for their survival. And compared with incident users of H2 blockers, PPI users are at risk of an estimated GFR under 60, with 19% increased risk, incident CKD 26% risk, and each GFR decline over 30% in 22%, and risk in those who are using these PPIs for a long time. And this is another Brazilian study. This is with 2 waves. They have first examined the baseline GFR from 2008 when they were collecting the patients to 2010, and the second wave after 4 years, or 3.9 on average, on the use of PPI, and they have estimated renal function with CKD epi, whether it goes below 60, like incident CKD. And you see here that in those using PPIs, there is a higher number of incident patients of CKD, but even more important, regardless of the adjustment model, we see that in those who are over 6 months using of PPIs, there are 44 patients who experienced incident CKD, and I said, depending on the model of adjustment, the risk is increased from 39% to 133%. This is something we all try to discover and try to treat our patients with, about the uric acid, lowering uric acids. And we all know about this scheme on how uric acid works on the vascular smooth muscle cells and other metabolic pathways. In this analysis, many studies have been presented, and mainly, although with a very low number of patients using allopurinol, they have showed reduction of uric acid and also associated in many cases with slower decline in eGFR, and also febuxostat was also the one who was showing the same decline in eGFR. But this is even better study. The CKD fixed trial have been introduced here with another trials to finally solve the questions whether we do have improvement when treated uric acid or not. And what has been presented, unfortunately, that in all of these randomized control trials, it was failed to be demonstrated that there is a beneficial effect of allopurinol or febuxostat on renal disease improvement or slowing the progression. Apart from this subgroup analysis in patients without proteinuria and those with creatinine below median, they have experienced in the treatment group significantly slower decline in eGFR with febuxostat. What about the bicarbonate supplementation? This is a very old idea, but there are some new drugs coming on the market. In this over 2 years in the treated group, it was shown that the survival of the kidney or the eGFR was significantly higher compared to control. And also the Polish Society of Nephrology has published this paper about when and how to diagnose and treat those with a low bicarbonate level. And they say, of course, if it is below 22, based on observational studies, we need to treat our patients. In this systematic review and meta-analysis, again, about the treatment of metabolic acidosis, you can see here that whether we use oral alkali or we use dietary intervention, in both cases, oral alkali, dietary intervention, to improve, to ameliorate acidosis in our body, in patient's body, we have a favoring intervention. So the treatment with substitution, with supplementation in this 3 to 5 CKD patient with metabolic acidosis, from 14 clinical trials, 1,400 patients, from 3 months to 3 years, use of oral alkali supplementation or reduction in dietary acid intake may slow the rate of kidney function decline and potentially reduce the risk of need for renal replacement therapy. This is also very tricky question, whether we need to prescribe to our patients keto analogs, since we all know that keto analogs are very expensive. And these are usually not on the covered by health insurance fund. In this meta-analysis, it is shown in 2 subgroups of eGFR below 18 and above 18, that there is favor of the treatment of keto analogs, you see. And these were also heterogeneous studies from 3 months to 4 years on low or very low restriction proteins and keto analogs substitution. And it was found that significantly this treatment with keto analogs delay the progression of CKD, and there is no problem with any acidosis or cause malnutrition or CKD-MBD problems. Especially it's important in those patients who are still above 18 milliliters of eGFR, so they have still free space in order to be protected. And what about very low protein diet? 0.3 grams per kilogram per day. But they in order to escape malnutrition, need to be treated either with keto analogs, but whether they can be treated with essential amino acids in patients in stage 5. Over 24 months period, it was shown that when treated with this diet and substitution with essential amino acids, CKD slowed down for 11 versus 9.3. So you see the compliant patient compared to non-compliant. Here is the risk for outcome for dialysis. In non-compliant patients, majority of them are going to initiate dialysis treatment. So it means that this very low protein supplemented with essential amino acids could be extensively used to reduce the incidence of dialysis treatment. And thus, of course, health insurance fund will have lower needs for the budget for dialysis. We are all listening about microbiotas. That is something new, which all of us are trying to understand. And it's true that during CKD process, there is proteolytic dysbiosis of this gut microbiota with the gathering of urinary toxins like indoxyl sulfate, paracresol sulfate, and these are per se risk factor for progression. A drug with symbiotic formula, probiotic and prebiotic in one unit, used for 2 months decreased these 2 products of uremic toxins. And the second paper also showed that use of this prebiotic, beta-glucan, in patients 3 to 5 stage for 8 to 14 weeks, favorably affected the gut microbiome and reduced these uremic toxins, which in addition should have reduced the risk for a need for renal replacement therapy. But this is good study, Indian one, on very low number of patients, but it's an idea, it's very nice. So 24 stable CKD patients, 3 to 5. And one of 12, half of the group, has been treated with low protein diet, prebiotic and probiotic supplementation, versus the control group receiving only protein diet. As you can see here, at the baseline characteristic of biochemistry, there was no significant difference, but after the treatment, you see the low protein diet has reduced to minus 11 compared to low protein diet plus probiotic that they have lost only 3.4 milliliters per minute per year. So prebiotic and probiotic supplementation along with low protein diet delayed the progression of CKD. Again, I say that this is only a small pilot study, but it's good food for thought in addition for any other randomized trial. Coming to the worst problem we have in our patients, that the diabetes is predominant cause, followed by hypertension and glomerulonephritis. I am sure that there are a lot of talks in our Congress about this, but what is a really disastrous way of perceiving the things is that for all the other complications of diabetes, there is a reduction over the years, apart from end-stage renal disease. You see that the improvement of incoming patients, diabetic patients to dialysis, has been reduced only for 28% compared to infection of 67%. So the protection for infarction has been much more successful. SGLT2 inhibitors and CKD progression in diabetic patients, yes, for sure. Whether it is stage 1 or 2 or 3 to 5, regardless, it's always in favor of treatment. They are reducing for 31, 41, or group 34% the risk of CKD progression and initiation of dialysis. And this EMPA kidney trial is the last in a row of many trials. I would like to show this trial included EGFR patient of mean 37, and 78% were below 45 and 34% below 30. And there was also measurement, of course, of the urinary albumin to creatinine ratio. And what was obtained as a result in this study, we will show, compared to placebo, of course, that there was a significant reduction of EGFR in placebo, and composite outcome of dialysis requirement or death eventually compared to empagliflozin. And second, regardless of the EGFR, this beneficial effect, regardless of the presence and absence of diabetes, again, this treatment with SGLT2 in EMPA kidney trial has been beneficial for the patients for the composite outcome, death or initiation of CKD. And coming to the last drug I would like to present, to finerenone. You see here about the study of the fidelity pooled analysis. And you have here the endpoint of kidney composite outcome, which is with the risk reduction of 23% and the need of dialysis of 20% in all patients who were treated with finerenone on top of the maximum tolerated doses of ACE inhibitor or angiotensin receptor blockers. Only few hyperkalemia, because that was the reasoning why we should not introduce this drug, but there is no such a problem with that. And you see the composite kidney outcome of reduction for 57 or reduction for 40. Again, very beneficial effect in all of these parameters in patients who were treated with finerenone. So we have obtained finerenone included in almost all association guidelines. And this is the last KDIGO guidelines, which included finerenone as recommended by KDIGO for patients with CKD and TIDVA2. A recommendation was to suggest non-steroidal mineralocorticoid receptor antagonist with proven kidney or CV benefit for patients with type 2 diabetes, EGFR above 25, and albuminuria above 30 with a maximum tolerated dose of RAS. So in conclusion, it's not easy. It's a comprehensive treatment for our patients, and they need to have a good compliance in order to get results, including starting with lifestyle measures and diet. PPI use we need to take into account very seriously. We need to supplement bicarbonate with and also with ketoglutarate or essential amino acid in those patients who are good compliant patients with low protein or very low protein diet. We need to consider pre or probiotic use. SGLT2 inhibitors in Europe for CKD indication, absolutely yes, as of today. And non-steroidal mineralocorticoid receptor antagonist used on the top of the standard care, absolutely yes. And we need to follow the guidelines. I thank you very much.